Like most first-year medical students, I wanted to be an internal medicine doctor. I wanted to diagnose people like you see on the TV shows. And that kind of stuck with me until my 4th year of med school. In April of my 4th year, and I was already lined up to be an internal medicine resident. And I rotated with a general surgeon who is vastly entertaining, and I really enjoyed his practice. And so in April of my 4th year, I changed my mind from internal medicine to surgery. Every disease process that I treat or I see, I have a friend or a family member who has that. So I mean, I do have personal knowledge of a lot of what people are going through. Just, not so much sympathy as empathy, so that I know where they're coming from. Not just the fact that I'm there to help them and to treat them, but the fact that I understand on a different level too, kind of what they're going through, what they're putting up with. I did my master's work at the University of Oklahoma. That was in biochemistry. I did my medical school at Oklahoma State University. I did my internship at Tulsa, Oklahoma. I did my residency in Columbus, Ohio at Doctors Hospital. I did my vascular fellowship in the same location. I did a year of a unpaid fellowship in laparoscopic surgery. That was in Chicago. I was in private practice briefly in Kansas. And then I practiced for the next more than 10 years in North Dakota. I was a trauma director there. And then the last 4 years I've been in Marietta, Ohio, prior to coming here. Vascular surgery in the last 15 years has progressed from a pure cutting specialty to a very interventional kind of specialty with balloons and wires and stents. And so that admixture is kind of a unique scenario. And because of that, there's lots of specialties that sort of touch on what I do, but don't do the full gamut of what I do. So interventional radiology does a little bit of what I do. Interventional cardiology does a little bit of what I do. Cardiothoracic surgeons do a little bit of what I do. General surgeons do a little bit of what I do. But all those small pieces put together generate really what is peripheral vascular surgery, which is the core of my practice. I've had more than one patient with a ruptured aneurysm, and all those patients are in the process of dying when you see them, and they feel like it, and they're feeling correctly that they are bleeding to death. And the first one of those that I did percutaneously, because now instead of having a big surgery, we repair those by sliding a new pipe inside the old pipe, which is what endovascular repair is. The first one of those that we did with local and very little sedation. So they were wide awake having this terrible pain. And the minute you fix the aneurysm, obviously it stops leaking right then. And that pain goes away right then, which I'd never really witnessed that, because normally you have those patients under a general anesthetic and they don't wake up for another day or two. And they usually wake up with a big incision, so they have all kinds of discomfort. So that was pretty impactful, and definitely for me was a proof of the success of that technology, which is relatively new. I mean, it was first done experimentally in '91. Wasn't really done in the United States until mid-'90s. And so for that technology, it's pretty phenomenal proof of just how good that is. To have someone truly suffering and you know the process and you know it's fatal, and they go from that to pain-free and the process is fixed. That's pretty exciting stuff, I think.